finish up with a view from Sandra Brekke, who serves as Senior Consultant to the Office of Population Health at Gundersen Health System in La Crosse. She received her undergraduate degree from UW-Madison School of Nursing and is pursuing graduate work in servant leadership at Viterbo University. She's been director of the St. Clair Health Mission, a free clinic for low-income and uninsured individuals in La Crosse for 12 years. And she serves as strategist for Gundersen's work on housing and homelessness prevention, as well as other community-engaged and trauma-informed initiatives. So thanks for being here today. Take it away.
Thank you. Well, so I'm not the housing expert in the room. I come from healthcare. In fact, my background is director of a free clinic, and if you know anything about social determinants of health and free clinics, 100% of our patients fall under the poverty level and are uninsured. And so they come with them a myriad of issues all related to the social determinants of health. And if you are looking for some of the solutions, go to your free clinics because they've been doing it for decades. They know that you cannot take care of patients if they're not housed. They understand nutrition and they're on the ground and they're doing this work and they have a lot to teach us. I love to show this slide, just give the UW Institute of Population Health a little bit of kudos. I think what is so prominent in this slide is that clinical care is 20%, but where does all of the funding go? You know, we are a nation heavy on sick care. We do it incredibly well, but the rest of that stuff we really are struggling with. The other thing I love about this slide, and that you don't see in other slides necessarily looking at population health, is length of life is 50%. But quality of life is 50%. In healthcare, we tend to focus on leading causes of death. Population health, what if we focused on the leading causes of life? How would we look at healthcare differently? And that's where we're going with population health at Gundersen Health System. It's moving healthcare upstream. And so everybody in population health around the nation is going, oh God, what do we do? How do we do this? Some of it is, you know, some health systems I've talked to are looking at population medicine. So it's disease states. It's are we checking hemoglobin A1Cs on all of our diabetics, and are we managing quality by disease? We are looking at it very differently at Gundersen Health System. We are looking completely outside our walls because what we know is by the time they get to us, oftentimes there's already an issue, and we want to try to prevent that. So how do we do that? And one of the ways the ways that we do it is we have to identify systematic patterns and what's happening and their variations. We're looking at a ton of data, constantly analyze data. We have a brilliant epidemiologist at Gundersen, Dr. Rooney, who can pinpoint neighborhoods where police are going, where we have truancy issues, where we have health issues, where we have lead in the homes. We have an abundance of data in healthcare. But what we are struggling with is how do we get out and do this? And in part because we're not funded to go out into the community and do some of this stuff. But really, healthcare has to create systems of health. And if we are moving to a value-based system from a volume-based system, this is imperative that healthcare moves outside our walls. Primary essential function of housing is to provide a safe and sheltered space. What the data shows and what the American Medical Association has said is, you know, the top 5% of ER utilizers use 50% of healthcare dollars. So what we did is we pulled our 100 top utilizers of the emergency room at Gundersen Health System, and then we actually focused in on the top 20 because they were incredibly high users of dollars. And what we found was almost all of them had been in and out of housing. An obvious target for us to go after in population health is housing, but how do we do that? Some of our other initiatives in population health is we're definitely looking at opioid issues. We are part of creating a community pathways hub, which I'll talk about just briefly here, but this is essential for social service systems to come together in communities and not work in silos. ACE and adverse child experience and trauma-informed care, I think, is the root of a lot of our issues, and so we're heavily investing in adverse child experiences and becoming a trauma-informed community. So looking at housing, what was really interesting is prior to my working at Gundersen Health System, I saw a 60-minute show with this crazy group in New York City called the 100,000 Homes Project, decided to house 100,000 of the highest risk homeless in the country, and they did it. And what was super interesting about it is they did it using the same strategies that we're using in quality improvement science in healthcare. And so when I came on to Gundersen Lutheran, one of my VPs had already heard Erin Healy talk, and we said, well, let's bring her. Let's bring her to La Crosse and see what she has to say about our community and if she can help us with our issues with housing and homeless. La Crosse is small compared to Milwaukee and Madison. We're on the side of the state that tends to get forgotten a little bit. But we are in La Crosse. If you look at Madison to our east and Eau Claire to our north, and then you're down into Iowa, we are the center for the homeless. So those homeless that are out in the rural areas are coming to La Crosse. So we have a higher homeless population than what you would think for the size town that we live in. So this was not hospital-led because we are not experts in housing, and I know that, and we all readily admit that. Population health is using the resources of the health system out in the community to really be the accelerator of the jet fuel behind projects that are already happening or struggling to take off. What can we use? How can we help with our resources to get things going? We already had a coalition around homelessness in town. We brought in Erin Healy, and it evolved to the La Crosse Collaborative to End Homelessness, setting goals to end homelessness in La Crosse. It's really been an amazing process to watch. This is an action process. We are not having conversations anymore because we know the issues. So we are moving. We are doing 100-day sprints to house people, and we do not let ourselves fail. It is innovative. Nothing is as is around housing in La Crosse and around our homeless. And celebration. This has been really tough work. A lot of people are putting in tons and tons and tons of effort. Ours is mostly private, nonprofit sector. Public has joined us, but this is really being driven by our nonprofit sectors in La Crosse. These are all of our partners, and we couldn't do it without every one of them. We have foundations, the police are with us, court systems, we have all of our shelters, the Y, health systems, we have our nuns. When you get the nuns praying for you, you know you're on the right track. So we started out with veterans homelessness. Our goal was to end veterans homelessness in 100 days. This was our first sprint. We all kind of thought we were crazy, but Erin Healy cheered us on. We worked with the Department of Veteran Affairs, and we had 16 homeless veterans that we knew about. We housed them all within 100 days, which was a 400% increase in the housing placement rate for La Crosse. Since then, we've housed 42, 93% remain in stable housing, and we are just about at functional zero with our veterans. We were the first city in Wisconsin to end veterans homelessness. So we were recognized on we're certified by the United States Interagent Counseling on Homelessness. Second sprint happened July 2017, which was our chronic homeless. We housed 20 of our highest risk. To date, we've housed 32 and 94% remain homeless. We are working on functional zero with chronic homelessness as well. Our sprint 3 was families and children, which I wanted to start first as a healthcare provider because it seemed like the most obvious thing to get children into housing, but it's incredibly hard to house families. There are not the resources around families that there are around the chronic and the veterans. So it has really been a challenge. Our goal was to empty out our Salvation Army homeless shelter of children, and we made that goal. So we housed all those families, and our goal is to not let any more children hit our shelters. Because in healthcare, what we know is we can predict the trajectory of a child's life. In fact, in population health, I think we should just tie our health systems to our schools, because one of the biggest predictors of the outcome of someone's health throughout their lifetime is a kindergarten teacher. So our schools are huge predictors of health, and they are not places that healthcare is looking. And what we know is that if a child hits shelter, their trajectory of life, unfortunately, can be predicted. And this is trauma. There's all the things that go along with that. So our goal in La Crosse is we don't want any more kids in our shelters. I mentioned this a little bit ago, Grace Hub. So we don't have a lot of public resources necessarily to do this case management. So another one of the projects that this is intersecting with is this Community Pathways Hub. This is a model, evidence-based model that's coming out of Ohio. It's being looked at, I know, here in Madison, and I think in Milwaukee is starting it as well. It is, in a nutshell, it is air traffic control for the social service system. We are referring people into the hub, and there they get a case manager from multiple different organizations in town. These case managers are all following the same pathway. So assessments are similar or the same across the community. People are assigned pathways, which are problems, and we are getting to the end of those problems. This is a braided funding initiative where the organizations are actually funded and paid by outcomes. So there is a pathway for housing in the hub. So when we have a high utilizer to an emergency room, we can refer them into the hub. They work with the Collaboration to End Homelessness with their care coordination people from the hub. When that person is housed, that agency is actually reimbursed for that outcome once they're in housing for 90 days. So we're using the Housing First model, but this is another way to reimburse the organizations who are case managing the people who are helping keep people housed. And this consists of public health nurses, social workers that are on the ground. We have community health workers as well. So all those people are out on the ground, meeting people where they're at, working on keeping them housed. One of the things La Crosse has done is we've joined Built for Zero, which is a national movement on ending homelessness. It's an incredible performance tracking tool. So we know exactly where everyone is at all times. We know exactly what our inflow rate is. We know what our outflow rate is. We are measuring the length of time homelessness. We know what houses are coming up next. So it's just as great for someone who's kind of a data geek. This is really fun for me to watch how well we're doing. And what it allows us to do is it allows us to shift course. So if what we're doing isn't working, we can see it real time and we can shift course, which is really important for a lot of the work that we're doing. And it shows our cost effectiveness across all sectors. This is a slide that actually is used by the 100,000 Homes Project. It's coming out of Skid Row in California, which just shows some of the cost to saving lives and public dollars. So it costs $63,000 to keep someone homeless. In California, $16,000 to house them. And it's even cheaper in La Crosse, and we're working on that. And this slide actually makes a big impact on people. And it did a lot of this is changing mindset in our community because, like James said, we have an incredible town. People actually love to donate to our shelters and volunteer at our shelters. And our goal is we're going to close our shelters. And so one of them will probably change to bridge housing, and the other one's going to close down because that is not how. Number one, it's not cost efficient, but more important to that, from a health system, this is a social justice issue. And as a health system, this is how we are looking at this. These are just some numbers we have from La Crosse. So we're starting really just to get initial data. We know what it costs in La Crosse. So now we're starting to follow people over time to actually see what the cost savings is. We have one person who is actually in the hub, was housed, and we've been tracking for, I'm going to say 6 months, but don't hold me to that. And we have 23 fewer visits to the ER this year than we did last year. So at a rate of $1,200 for an average ER visit, that is already showing cost savings to the health system. The solution really to the homeless issue is we have to infuse money into upstream prevention. And that's where we're moving. We are changing our system from a crisis system, and we're really putting resources into upstream prevention so that over time we can decrease the more expensive downstream system. So this is really important to what we're doing, is really shifting that funding. Dr. Curtis talked about the shock to a family. Our goal is to fund that shock. We don't want those shocks because we don't want any families losing their housing. And so we have, we're creating systems and money and lots of work going on so that we don't have families who are entering the homelessness. And I went really fast. I was trying to keep watching the clock here. So housing is healthcare. You can't argue it anymore. There's too much data and too much research out there to show that if we do not house people and we do not have people in secure housing, we cannot provide our best health care. And so health systems have got to get into this arena in some way, somehow. I think every community has to use its own creativity, but we definitely need help from policymakers. We are saving Medicaid money. We need these policymakers at the table really looking at this issue, looking at all sectors. We're saving jail, we're saving police, we're saving, all sectors are being impacted. And in healthcare, we look at the triple aim, and one of them is to lower costs. Well, maybe we're not always lowering our bottom line, but if we're lowering the bottom line in the community, then we are impacting the cost of healthcare. And this is how we are looking at this at Gundersen Health System.